ONtheGO Podcast.
Today, we will discuss life at the ICRS World Congress 2025 in Boston, Why Hips Don't Lie. Professor Aaron Krych, Department Chair of Orthopedic Surgery at Mayo Clinic, talks about preserving before it's too late. In a coffee break with Dr. Jari Dahmen, Amsterdam Medical Centers, University of Amsterdam, as well as with Dr. Chris Nagelli, Assistant Professor at Mayo Clinic. My name is Takao Shima, and this is On The Go, the podcast all around ortho regeneration.
Welcome to everyone who's sitting here, and welcome to our listeners. We're currently at the ICRS in Boston, which is being held here, and we're super excited about the content here and about a new episode of the ONtheGO Podcast. And we not only have a very special guest with us today, but we also have Chris Nagelli, who will be running the podcast from the American side of the ON Foundation. And I'll shortly give the word to you to introduce yourself to our listeners.
Thanks, Jari. Happy to be here. Happy to be part of the team. So I'm an assistant professor at Mayo Clinic, studying cartilage and meniscus repair and ACL reconstruction as well. I'm happy to be here, and it's Boston, and it's Joint Revolution, ICRS 2025. It's a great time, and we're having a great conference, and it's my honor to also be with Dr. Aaron Krych here. So Dr. Krych, we're going to start with some personal questions, some icebreakers. So first off, do you drink coffee?
I love coffee. I don't drink it in the morning. I usually just am kind of running in the morning. But I like some coffee in the afternoon as a pick-me-up. So I'm usually I like my coffee smooth and strong. So for me, I like cold brew coffee. Mm-hmm. So longer steeping of the coffee grounds. That 12 to 24 hours gives you a little higher caffeine content, which is nice and strong and bold. And then I like the cold brew because it's not as acidic. You're not getting some of those other kind of bitter flavors. So it's for me, it's the oils are intact. It's a bit smoother. So I really like the flavor. It's kind of a chocolatey, nutty, smooth and strong flavor. So I really enjoy that in the afternoon. That keeps me on track. So
so it's to pick you up. So it gives you some energy. From what moment in the day do you need that? Is that 4 p.m., 12, 2 p.m.?
I think for me, it's about that 2 p.m. It seems things get a little sluggish then. You just need a little pick me up to keep things going at a high rate. So
just going towards the Mayo Clinic, because I'm sitting here with two Mayo Clinic employees. So you guys are the majority here. But could you tell us a little bit about your journey, how you ended up in the Mayo Clinic, and how you became an orthopedic surgeon, and how that went?
Yeah, well, thank you. Everybody's story is a little bit different, but I would say that Mayo Clinic is the best thing that ever happened to me for a couple of reasons. So, but it's about the people I met. So I started in medical school at Mayo Clinic and actually met my wife there. So we were anatomy partners, essentially, assigned anatomy partners. Yeah. And I think with all the dissection and things, she got a little confused, and I took that as an opportunity. So long story short, we got married, and it's been fantastic. But the other part of it was I also met one of my mentors there early, Mike Stewart, who was a sports surgeon. And we had a little bit of time, like the first week. So I spent one day in clinic and one day in the operating room with him. And I'm like, from that day forward, I wanted to be an orthopedic surgeon. I wanted to be a sports surgeon. And really, he was very inspirational, is very inspirational to me. So that started my Mayo path. And then I ended up staying there for residency. My wife and peds, myself in orthopedic surgery. I finally got away for a year with fellowship at special surgery in New York. Worked with some great people there, Dr. Russ Warren, Dr. Scott Rodeo. Dr. Suzanne Maher from the PhD side, and then came back to Mayo Clinic. And it's been just a great process, a lot of personal and professional growth, and have really enjoyed having Chris on the team as well. So
great. Thanks, Dr. Krych. We were going to ask you about who are your influential mentors, but you touched on that a little bit. So I wanted to ask you about some of your clinical research. Now you focus on meniscus repair, cartilage repair of the knee and hip. I wanted to talk to you about a little bit more about hip cartilage and just where we're at right now as a current field and what your research interests are in this field.
Yeah, so hip is an interesting area, and we've learned so much from our knee experience and our knee colleagues. I think we're talking about now those other joints where cartilage is really making an influence, and we mentioned ankle, of course, and then the hip joint. And for me, I like to bring everything back to my patients, in clinic, and really figure out where are their unmet needs. And the hip joint for cartilage is definitely one of those areas. So, we see a lot of patients that have, mechanical reasons for problems in the hip. They develop impingement at a very young age and get cartilage damage, very early on. And really, historically, there weren't many options to treat, those cartilage injuries and those cartilage defects. So I think, again, learning what we've found to be successful in the knee and try and apply that to a different joint, I think is what has kept me going, and ultimately seeing those patients in clinic and be able to offer them something to really bridge that gap of care, that they have currently.
Mm-hmm. And from a clinical point of view, how is your current approach to hip cartilage lesions? Could you tell us a little bit more, what your way of thinking is concerning treatment? Yeah,
so the most common hip cartilage injury we see is really in that hip that impinges. So yes, we see some traumatic lesions, hip subluxation dislocations. We can see it on the other side where we have undercoverage and some dysplasia, but where we see the focal cartilage lesions, which we think are treatable, really is in that impinging hip, population. And when you look at the history of it, it's a brief history, but what happens in the hip with the large cam bump is you get this delaminating flap. So some early on tried to repair it. There was a question of, is that cartilage viable or not? We didn't always think so. So then, essentially began kind of debriding it. And then some did marrow stimulation or microfracture. And that became very popular because when you looked at the data, those patients got better. What I always questioned was, why does that athlete with a hip microfracture get better? Is it truly the microfracture, or is it the cam lesion they've removed, the labral repair that they've done, the rehabilitation that they've done? So we finally looked at, a comparison study. So microfracture of the acetabulum, of that focal area versus removing that flap and debriding that cartilage. And in fact, we found no difference. So both of those groups did better after surgery, but probably because we removed the impinging lesion, we repaired the labrum. So that really helped us then at least use debridement as a comparator moving forward. In the knee for a long time, we were using microfracture. We all know how that, story went in terms of, not being very durable and having some problems, with intralesional osteophytes and things. Mm-hmm. So at least we started there, was our starting point, with debridement for the hip. And then the question is, what else can we do, to restore that cartilage defect?
Yeah. So there's many challenges that you've already overcome over the past decade. Then I think in that sense, what is something you're looking forward to with regards to the future? So say in 2040, where do you want to stand as a hip surgeon, a preservation surgeon, with regards to those cartilage lesions? Where are you working towards to?
Yeah, I think we're learning a lot, but we still have a long way to go. I think the first question we always have is who gets into trouble. Oftentimes we see bilateral deformities, but only one hip is really getting into trouble with cartilage damage. That's symptomatic. So going forward, I think we need a way to rapidly diagnose these hips. So we have imaging. The question is, do we need some sort of, rapid bioassay where we can look at your marker profile? I think it's they all have mechanical issues, but I think it's the ones that get the biochemical issues on top of it. We see synovitis, we see that inflammation. I think those are the ones, that are really getting into trouble. So having a way to identify those patients earlier. So I will rely on my smarter translational scientist colleagues to help. And then, so once we've identified who's at risk and who's going to progress, because again, a lot of these we just get to too late, and it's not an age issue. Sometimes 18-year-old, 19-year-old hips too late because they've been suffering and kind of putting up with it. Yeah. So once we identify it, then it's, how do we best treat it? And the hip is a little bit different than other joints in terms it's a very deep joint. A single surgery, even arthroscopy, you pay a high price of tuition because you have to cut through the capsule. So clearly we need something that's single stage and arthroscopic. I think, when we started out 20 years ago, we were doing surgical hip dislocations and things, but obviously, arthroscopic, is better. And then creating, a durable option that we can, rehab in a quick manner and get people reproducibly back. So I think there's some other technologic, advances that are going to help us, in terms of being able to predict the bone that we need to resect for impingement. I think it's a little bit like this right now, where we have some x-rays, we look at it through the scope, but we don't really know for that individual patient and what they need to do, for their sport and activity, where to resect bones. I think, virtual reality, virtual augmentation, planned, resection, I think will be a big part of this. And then obviously, the biologic side in terms of treating the cartilage. So again, over the next 15 to 20 years, those are the areas we're really looking at, better diagnostics, who's getting into trouble, better execution at the time of surgery, and really, better biologics for a better outcome.
Yeah, great. Thanks, Dr. Krych. Can you touch upon a little bit of the data that was presented here from our group at Mayo Clinic, some of the new innovative cell-based techniques, but also things that we've been working on for regarding transplantation and joint preservation at the hip as well?
Yeah, so I think the most exciting thing we're doing right now is reclaim for the hip. And this is a single stage, technology that was really developed in the knee. And it started in Utrecht with, Daniel Saris developing it on the clinical side, and Luciana Bonk, really on the scientist side. And what it is essentially recycled chondrones mixed with allogeneic MSCs. So it allows, a single point of care that are implanted into the cartilage defect at the time of surgery. And initially that was shown to be successful in phase 1 studies in Utrecht. And then Daniel Saris moved continents and came to Mayo Clinic. And I think what's unique about this technology is then it was essentially redeveloped at Mayo Clinic as Reclaim. So the allogeneic stem cell source was a little bit different, but the cartilage technology remained the same. And we were able to, perform phase 1 studies in the knee with really comparable positive results, no safety issues, good efficacy, for the patient. So I think it really proved the model that, it's the cartilage cells that really become the cartilage repair for the tissue. The MSCs go away, over time. And there are a lot of aspects of that were very appealing for the hip. So single stage, arthroscopic, minimally invasive, being able to provide that, for the patient. So that's when we went into the hip and we completed a trial of 15 patients. The FDA allowed us under an IND phase 1 study, and we're able to treat those delaminating defects we talked about that previously don't have, any good options other than debridement. So we've treated those patients, and just like the knee, no safety issues, and they seem to be responding well to that cellular therapy. So we're very excited about it. I think it gives our patients some hope, when you talk to them in clinic about their cartilage damage, in a very young joint.
Yeah. And I feel like it's also a project that functions as a stepping stone towards more projects or even more elaborate projects on this specific manner. Could you maybe give us some thoughts of future projects that are going to follow up on this reclaiming the hip? What are you thinking about?
Yeah, so we're excited about the hip. I think we need to really, confirm some of the results there. Then the question is, now we have other colleagues lined up. So we have one of our foot and ankle colleagues lined up. He really wants to do it the ankle, and we have a shoulder and elbow colleague. They want to try it, the shoulder and elbow. So I think other articular cartilage joints, absolutely. But then the question becomes, is there a more of a platform model here for really tissue healing, when we perform surgery? So that concept of recycling patients' own cells, the autologous part, really trying to enhance those cells, with MSCs, and then using that to really improve, repair of tissue. And when you look down the list of tissues we're trying to repair in orthopedic surgery, rotator cuff and meniscus and, peripheral nerve and all these different things, there's really no end, to that list. So I think it would be fun to try it outside of articular cartilage. And we've done some preclinical work in the lab for meniscus, looking at isolating those meniscus cells, or those meniscons, as we call it, and trying to develop, that proof of concept. But I think this could be a potential, platform technology to really help repair, a lot of the tissues that we aren't always perfect at the time of surgery. So.
Yeah, that's amazing. And you previously mentioned also about the two different groups, the groups that are at risk of developing, for example, cartilage lesion or dysplasia or other diagnosis, and the group that is not at risk. And you mentioned we need to get more information and more science on identifying who's who. Saying from your personal experience that you've had over the last decades, who do you think is really a risk factor for group A and for group B, and what science is needed to really identify those both groups?
Yeah, I mean, that is such a fundamental question, because when you take a step back, it's really about what causes pain in our patients, right? So we're obviously interested in structure and, preserving the joint, right? But ultimately, as someone who treats patients that are suffering, I'd much rather, I want them to feel good. I want them to have a high level of function, et cetera. So until we really understand what causes pain in some of these joints, I'm not sure we'll make, the next leap. And you asked for personal experience. I'll give you some very personal experience. So I have impinging hips, both sides, radiographically look equal. About 10 years ago, I had a hip arthroscopy on my left side, removing the bump, repairing the labrum. There was some cartilage damage there, but we didn't have good options at that time. So that side, feels much better, but my right side looks the same, but I have no symptoms, on that side. And what is it about that? Is it a mechanical issue? Is it biochemical? Like two joints in the same human, one's symptomatic, one's asymptomatic. And those are some things that we fundamentally have to understand better, in order to move forward.
You wish you already had the reclaim back then.
Yes.
Okay.
Well, Dr. Krych, as you look towards the future, both as a researcher and a clinician, maybe 10, 20 years down the road, where do you feel like the field is moving towards? What would you, if you had a whiteboard and you can do anything with the future, what do you think we could definitely concentrate on to not only improve current research, but also find some therapies for our patients?
Yeah, I think, a lot of things we talked about, earlier detection, understanding, pain generation, but just so many of these joints that we see, again, it's very young patients that present too late. So I almost take a step back, because we're seeing those patients that get to our clinic. So I'm thinking more broadly, how do we as a society, identify those patients and screen for those, potential patients earlier. So for the hip joint, some ideas we've had, for example, athletes are at the highest risk. And the question is, can you screen? They really require physicals, every year. And typically, a general physician is not, really intensely screening, but maybe we should start screening and trying to find, some of those at risk. Your work is also in biodynamics and biomechanics. So certainly you understand how we can identify those at risk, not only in the hip, but in the knee, in the ankle, and elsewhere. So I'd like to really see us broaden that out beyond the walls of our clinics, go into our communities, and how do we, really help educate and help identify. I think that would be, much more meaningful in terms of preventing cartilage injuries, before they happen.
Yeah.
I think that also brings a good bridge to a next clinical question that I would be interested in hearing what your thoughts are. But if you could step in a time machine and we're in 2040, 2045, and you're a hip surgeon, how do you think practice is going to be different than when you, for example, on Wednesday return to your practice? How is that going to be different in all aspects?
Yeah, I think, obviously, any question where you're looking at the future, the answer is going to include AI. And I think something that Mayo Clinic is developing in other areas is this concept of digital twinning. Because again, it's all about prediction. I spend most of my time kind of crystal balling, if you will, with my patients and hypotheticals of what could happen. But if you knew what was going to happen, if you're able to predict it with a high level of certainty, then that would really allow you to make better decisions, in the present about activity level, interventions, et cetera. So I see digital twinning as a way, can you simulate, okay, what would happen to this patient if we intervene now with surgery, for their hip, where you move the cam up, et cetera? Would that alter their natural history? And that would, I think, allow patients to help make better decisions and really be well informed about what they would want to do. But I think I think that would be the really good part about it. I think even our large databases now, they fall short for an individual patient. We know how a group of patients will do with the treatment, but in terms of predicting an individual patient, and that's where I'm excited about having big data, AI, and digital twinning be one example.
Yeah. I think we're slowly moving towards the final stages of our podcast, and the way we started with getting some more personal information and getting to know you, we're also ending it like that. We always ask the question, who inspires you, but we touched upon that. And Chris told me that you're currently also the department chair of the orthopedic surgery department. So you're not only doing orthopedic surgery and working as a clinician, but also in that sense as department chair. What is something, or maybe the top 3 things that inspires you on a daily basis to work with students, residents, orthopedic surgeons, scientists? What 3 things are inspiring you on a daily basis?
Yeah, good question. So I try to take what we call a servant leadership approach. So what's fun about being the department chair is I don't have to think about myself as much. Now I get to think about everybody else and really how to help unlock their potential. So trying to align those interests and seeing what doors you can help open for them. That is the fun part. I think early in our career, everything's focused on ourselves, and it's much a finite game. I have to get to undergrad, I have to get to medical school, I have to get to residency, but at some point you can flip the script and now it becomes an infinite game where you're now focused on really the success of others. And that is immensely rewarding. Those victories are savored much longer and personally satisfying. I love the process of growth. So that's something I try to emphasize, that journey of personal growth and professional growth. I think a lot of times, particularly with residents and fellows and students, their focus of control is external. They're living out here and they're comparing and they're on social media and this and that and the other. Yeah. But really their locus of control needs to be internal. And how do they personally become, the best version of themselves, in an authentic way. So I think really, just then you embrace the struggle and the process and ultimately, getting better. And I think those 2 things in combination have been really fabulous. It's been a fun journey.
Wow. Yeah.
Great. Yeah, I would say that working with you for the past several years, I think you really embody all of those things really well and have been a servant leader for not only our laboratory, but our division and our department as well. So we're really excited for the future and everything to come at Mayo Clinic. So I wanted to ask you a little bit about maybe some topics that weren't as serious as we were just talking about. What is your favorite food?
Oh, wow. My favorite food. I like to eat, so this is, there's not a limit of choices here. My favorite foods. My wife is an incredible cook. I mean, she really does an amazing job, but she, I don't know if there's one particular dish, but it's just the concept of, like healthy, nutrition. That's really good. Like that's a tough combination. So I don't have one particular food, but I think when we're able to, cook with fresh ingredients, local, you kind of get that farm to table, like that is all, very appealing. And there's a broad variety of that, but I think it's about food that makes you feel good, like after you eat it. Yeah.
Yeah.
And then maybe that food question brings us to a question of what is your guilty pleasure?
Guilty pleasure. Wow.
After a long, hard day or a clinic day.
I love American football. So, if American football is on, I will definitely watch it. I just love the games. I love the players, the personalities. So, yeah, I could definitely watch football for long periods of time. So
all weekend long.
You got to be careful.
Yeah, for sure.
And I think we're working towards the end of the podcast, and we're slowly finishing off. One last one for our listeners, because the listeners are all connected to the ON Foundation. In your point of view, with your experience that you have gathered over the years, what will be your most important advice for starting scientists, clinicians that are just starting in the ortho generation field? What would be your top one advice?
Well, we're here, at the World Congress of ICRS in Boston, and I think really it's on full display. It's collaboration. That's what makes, our field very special. Just to understand, I don't have all the answers. I'll have my perspective, but I have good people like Chris that have a very different perspective, very different skill set. I think it's about forming those teams and collaborating. Just realize that, you have a part to play, but that you're part of something bigger than yourself. So I think that's what really makes our field special.
All right. Collaboration is key in that sense.
Yeah.
Amazing. Well, thank you so much for being the guest on our podcast. We really enjoyed it. And also great, Chris, for your first time here and the beginning of your podcast journey in the US. So we're really excited about that. And thanks to both of you.
Thank you.
Thank you.
All right.
This was On The Go, the podcast on ortho regeneration. For more content, stay tuned at my.on-foundation.org. Thanks for listening and have a great day.